Well, I'm now talking to Leanne Karu. Now, Leanne, you're going to tell me your precise title. Now, I've got you as a prescribing clinical pharmacist, but I think it's more extended than that. You gave the most awesome workshop today on your contribution to a team working in a rural area and how your skills are just enhancing the group, they're enhancing patient care and enhancing the well-being of the community. I was genuinely moved by what you had to say. It was just lovely. But so can you tell the purpose of this is people who didn't listen to you, so we're going to condense your wonderful talk into 2 minutes. So can you remind me what your message was and what you're getting across?
That's really hard in 2 minutes, isn't it, Buzz?
Yep.
So I guess the technical term is Pharmacist Prescriber. It's a fairly new thing, so understandably a lot of people don't know about that. And I did identify in there that actually, in terms of the pharmacy profession, we're not very good at letting the public know what we do, and certainly not other health professionals.
Mind you, you're a rare breed. There's only 7 of you, I think, in the country, is that
well,
right?
Yes, in primary care only, in terms of pharmacist prescribers, yes. So it is a new concept, and I guess it's just sort of unraveling a little bit of that for GPs that are here. What does that actually mean? What does that look like? How does that help me in my practice type thing? So. Yeah.
And certainly a lot of the patients which we have are products of I'm going to be a bit controversial here, products of a fragmented healthcare system. So Dr. X, Y and Z are prescribing whatever they're prescribing, and the patient at the end of it may or may not be taking whatever they're prescribed, and what they are prescribed can often snowboard into a mismatch of stuff which shouldn't be there. And then you appear and they see you, and thank God you tidied them up, but you do more than that, don't you? I was impressed with what you do. So can you just expand on that?
As you were saying, it is a fragmented health system. I'm not sure if it is controversial to say that, or if we are just being realistic. And certainly rurally, we all know, the extra challenges. The health system is hard to negotiate anyway, let alone when you are rural. You do, I guess, by the nature of that, you do have to default to being in a more collaborative environment. And certainly the one that I've been has been very supportive of that. And I guess that's one point, is that a lot of people think that pharmacist prescribers work inside a community pharmacy. Really clear that we're not part of that at all, and in fact that's contravening the legislation, that we do have to work collaboratively inside a health model, inside of a medical system, and the evidence for working outside of that is not there. It's not helpful for us to be working in a community pharmacy, even if there wasn't the whole ethical issue of making money on top of prescribing sort of thing. So
So how do patients get to see you as part of the team? Where does that triage process come in? So they're lucky enough to have you.
Well, when I first was implementing this role, it was through the DHB, and something that we don't normally do, but went to the DHB and said, look, you need to employ me, Pretty big statement, but I was kind enough that they were kind enough to give me a pilot, and I was clear in that people could come to me by various mechanisms, and that continues to be the case today. I do consultation with the community, really mindful that the community needs to have input into this. I think Lance O'Sullivan identified yesterday that, when the community takes ownership. So I spent quite a bit of time going around various hapu and iwi collectives, talking with whānau about how that might look. It's all very well for Leanne Karu to say, oh, here I am, come see me, but actually needed to have some input into how that might look.
Right. So do they self-refer, or do the GPs
So they can self-refer,
right.
Or else GPs can refer, the Māori health provider can refer. You can come by whatever mechanism you like, and you're not going to pay for it.
And it's free as well.
So that was my other point.
You gave some lovely examples of where, with the best will in the world, there were some patients who would just, I can't think of a better word, inappropriately prescribe what they were prescribed, and how you sort of unpacked that and then got them on the right track. That was just lovely. How long does that take? Is it an hour's consult or several hours of consult?
Yeah, I like to talk about cultural literacy, Buzz. I mean, it's quite a big term, but sometimes it might take an hour. I guess that's, fairly generous. Usually it's probably 30 to 40 minutes of that initial time, because, you're peeling back a lot of layers there to, really find out what's important to people, what they know, and to provide messages to them that they understand. I think I had one of the most points that I thought was really good recently when a man said to me, Leanne, you can tell white messages in a brown way, and and that's why I've been referred here, because that's the word on the street. So, well, that's really generous, but if I could live up to that, absolutely. So it takes a lot of that to start with before you're thinking pharmacologically. What could I do here for this person?
And so the model you present, it was genuinely compelling listening. It really was. But it almost made me think there aren't enough of you. Is this going to be rolled out? Are we going to see many more of? Well, not you,
I hope
but
so. But
yeah.
I mean, the eternal issue, funding,
Yeah.
and
But-
certainly I've struggled myself in that space, as have we all.
Yes.
Yeah.
I certainly remember in Australia when they got the Home Medicines Review program going, the cost savings for doing that justified the expense hugely. And
Right.
the cost of prescribing errors is millions, isn't it, a year?
Absolutely it is. Well, we don't even know how many there are. So I mean, we think we know about 5% of them. So.
Yeah, oh right, I'm with you. Good point. So
Yeah.
the more of you we get, the more we'll save. So we can almost say we can't afford not to have you, which is I like that thought.
Thanks, Buzz.
The people listening, especially the doctor prescribers, that we are, one could argue, appropriately threatened by the rollout of designated and delegated prescribers for non-doctors. How do you see that going?
Yeah. Well, I think we're really overt that we have one piece of the jigsaw puzzle, and it's a very big jigsaw puzzle, isn't it? So, we have the pharmacological expertise, but it's very much has to be in a collaborative environment. Historically, pharmacists haven't been the hands-on people. Our assessment skills and our diagnostic skills haven't been something, that certainly we would want to be talking too much about. So, it has to be in that collaborative model. I absolutely rate GPs. Which is fantastic, and I'm working all the time with the GPs I work with. They're in my room as often as I am in theirs, and I think surely that's what it should be about each of us sharing those skill sets.
It's impossible to disagree with you. Is our environment globally collaborative enough yet, or can we use a simpler word? Is it there? Do we need to make some changes so we can have more of you dropping into that, or are we ready to roll, do you think?
Yeah, well, I guess there's a bunch of sort of obstacles in the way to start with. But
it's a leading question. I knew they were. What obstacles are they?
Funding's a big one. Yeah. Funded roles. Currently we sit outside of any funded role mechanism. PHO land hasn't wanted to know about pharmacist prescribers to date, and the community pharmacy budget. That's how community pharmacists are funded. We sit outside that as well. So it's a little bit of this hiatus of sitting nowhere, and who's going to fund these roles. So hoping to really sort of generate some good data or robust data around the current prescribers, and maybe use that as some leverage for a demonstration of further worth.
Fingers crossed. Your talk was compelling. It was incredibly powerful, and I think we need to evangelise what you were doing. You're going to have to give that talk again in different places. Your details are available on the website, I presume.
Well, Māori Pharmacist Association.
Yes.
We have our own website, and my name is on there, and anyone's always welcome to contact or email me.
Well, I'd encourage
that.
anybody to invite you to come and talk. It was really genuinely, truly compelling. So thank you very much indeed.
Thank you
really
so
appreciate what
much,
you did.
Buzz.
No, you did great. Thank you.